Good afternoon, everybody. As the baby-faced one of the bunch, it fell to me to look into papers in the literature of treatments that may be available in the future when I'm a bit more silver trauma than I am now. The difficulty with that is, these are things that aren't being done yet, and it's hard to write and publish about things that aren't being done. So I needed a bit of a steer, and I found it in this paper written by Karen Broe and published in the Journal of Intensive Care Medicine last month. It's called Why Do Bleeding Trauma Patients Still Die? And it reflects the sad fact that with enhanced pre-hospital care, more and more severely bleeding trauma patients are arriving at hospital. And yet, precious few of those people are surviving to discharge at the other end. And the paper proposes that this is why new management paradigms that enhance pre-hospital care I mentioned bring patients who have sustained greater injury loads, more ischemia, more inflammatory activation, and more cell death. Now, for a short editorial, it was pretty comprehensive, and it even went on to suggest a solution. We need innovations that better manage prolonged ischemia, cardiogenic shock, and persistent multiple organ dysfunction. So using life-threatening hemorrhage as the example, why are patients getting ischemia, cardiogenic shock, and multiple organ dysfunction? Is it something to do with what we do to them? The photo on the right representing permissive hypotension, allowing shock to build up. The photo on the left representing aortic occlusion, perhaps saving the life from immediate life-threatening hemorrhage, but at what cost? And how do we measure this? What individual dose of shock can our individual patient tolerate? Some might call it their shock tolerance. No one really knows what your shock tolerance is versus yours, or indeed mine. Whatever blood product or volume you choose to put in there, avoiding hyperresuscitation is important, but on the flip side of that, how much ischemia can each individual tolerate? So looking at the ultimate ischemic state of cardiac arrest, how much ischemia can each brain tolerate before survival of that person is completely impossible, regardless of whether you gain ROSC or not? In trying to answer those questions, I've created for you my future files, and these are what you're going to get access to at the end of my lecture. The first thing we're going to look at is a clinical trial being done in Norway looking at out-of-hospital cardiac arrest for medical cause and delivering Reboa via Norwegian HEMS. These guys are running a registered clinical trial just now. They're trying to optimize coronary perfusion pressure, aortic pressure minus right ventricular pressure. And the theory is simple. You're doing CPR, you generate 30% of your normal cardiac output, occlude the aorta, and deliver it to just 30% of the body. You improve coronary artery perfusion, you improve cerebral artery perfusion, and hopefully generate some more intact survivors. They haven't got any data on that yet, but they have shown they can get the balloon up in about 12 minutes after arriving on scene, and they can do all of that without making any compromise to the quality of the ALS. Staying with aortic occlusion for a second, we've just heard from the man himself about selective aortic arch perfusion, essentially taking a wide-bore aortic catheter, that's a photo of Jim's that is being in development, a wide-bore aortic catheter, Reboa catheter, occluding the thoracic aorta and infusing either whole blood or maybe a synthetic oxygen carrier up it. Jim's done some animal work on this that he chose not to tell you about, but it's in my future files. He took 30 pigs, divided them randomly into 3 different groups. The first group, they were all given traumatic cardiac arrest with exsanguination by a liver lobe injury. The first group received Reboa and then whole blood given via a subclavian line. They all died at 60 minutes. The second group received SAP and were given lactated ringers, or Hartmann's to me, via the SAP catheter. 10% of those survived. The final group were given SAP, and up the SAP catheter was given oxygenated whole blood. 90% of those survived. So maybe we're making some progress and we're starting to manage this ischemia, but haven't addressed anything to do with the brain itself yet. So here's something way out off the cards. A top secret is not top secret, but it's not published yet, project called Brain Freeze. Its real name is Emergency Retrograde Selective Cerebral Perfusion. Those of you that do cardiac surgery, think about your antegrade or retrograde selective cerebral perfusion. We put the patient on coronary bypass, we put our cerebral perfusion catheters in, we cool the brain and perfuse them while the patient's in deep hypothermic circulatory arrest, and it wins us back maybe about 30 minutes of circ arrest time before we begin to get unmanageable cerebral edema and the patient dies of a neurological injury. This suggestion, brain freeze, is an emergency adaptation of that technique. You take an occlusive superior vena cava catheter inserted via the IJ, occlude the SVC, and then infuse ice-cold saline proximal to the balloon. That ice-cold saline then flows up the jugular venous system into the brain and perfuses it backwards. Now, the guy studied it by using technetium-labeled albumin as a surrogate for a red blood cell. that technetium-labeled albumin wasn't really crossing across to the arterial side, so it's not strictly retrograde perfusion, and they hypothesized that it might be effective at increasing survival by causing deep and uniform brain cooling and flushing out any arterial microemboli. Let's have a look at something that is even more crazy still, codenamed CARL. This one's not top secret. They have published one case report. Not much detail in it. Feel free to have a look at the end. CARL stands for Controlled Automated Reperfusion of the Whole Body. I don't know where the L is. I think it's because there's an L in whole. These are the machines that do CARL. It's called the CURD machine. On the right is the CURD, your left, sorry, is the CURD 1, and on your right is the CURD 2. This thing's really clever. You put large bore arterial and venous cannulae in. The CURD machine samples the blood automatically for you. It does all the arterial blood gas parameters, it does AST, ALT, and neuron-specific annulase. It then goes on to autonomously modify the contents of the blood that it's returning to you. It autonomously modifies the temperature, the pH, the oxygenation, and it alters its own flow itself to optimize the reperfusate, whatever blood you're being given back after your state of profound whole-body ischemia. The really clever thing is it does it itself. In fact, it doesn't just do the oxygenation and the gas flow itself. It even does electrolyte correction and things itself via an infusion module. You just hook up calcium, you hook up potassium, you hook up whatever you want, and it will run it all in itself. And CURD 2, on the left, is about the same size as the Maquet CardioHelp, the pre-hospital ECMO machine. Imagine where that could go. And let's look at one more thing, even more crazy still. We've looked at whole body perfusion, trying to return things back to normal. And that's what we always try and do. Think of our neuroprotective measures for traumatic brain injury. It's simple, isn't it? We just try to normalize everything to normal homeostasis like you and I have got now. Well, here's something that's so far off-piste and going so far away from normal, I can't quite imagine anything more strange, and that's EPR. These guys in Baltimore are doing a registered clinical trial, a feasibility study into EPR, emergency preservation resuscitation. And it looks a lot like this without all the space-age equipment. For those of you that don't know EPR, take a patient who has a penetrating injury to the thorax from which they're exsanguinating. Do a thoracotomy and put on an aortic cross-clamp. At that point, using Seldinger technique, cannulate the aorta under direct vision. And you're going to flush into the aorta at 2 to 5 liters per minute, ice-cold saline, 4 degrees saline, actually. Having started that flush, you have to give a rapid flush, like Jim said, to close the aortic valve, then you continue to infuse up to 5 liters a minute of 4 degrees saline. Having established that flush, they open, under direct vision, the right atrium and cause the patient to exsanguinate the entirety of their blood volume into the thorax, which is sucked out into a Yanker and discarded. That cooling is continued until the patient reaches a tympanic temperature of 20, at which point the aortic clamp is released and whole body cooling takes place down to a tympanic or nasopharyngeal temperature of 10. At a tympanic or nasopharyngeal temperature of 10, the pump is stopped. The flush is stopped and the patient gets taken to theater for an up to 2-hour damage control surgery operation of no flow at all. In an animal study, between 60 and 120 minutes of circulatory arrest, 100% of the animals survive with this technique. After the hemostasis has been achieved, which I think is an ironic term because they've got no blood in them, they put the patient with formal cardiopulmonary bypass catheters and give them some blood volume back and gently rewarm them using bypass, at which point they go to the intensive care unit. So the content of my future files has been pretty out there stuff, especially this. And I'm not saying that any of these things are the answer. In fact, some of these things may never even be used on a human. But the time for managing that ischemic burden, that inflammatory activation, and that cell death, that's right now. And we really need to start to eliminate that delayed death effect, which is emerging as a result of excellent pre-hospital resuscitation. The paper that I introduced you to right at the start finishes with this. Focus in these areas may herald a new era of trauma resuscitation and a future generation of new survivors. I really, really hope it does. Grab your phones out, get your QR scanner, scan that, and once you scan that, it'll open this document, it'll PDF. It'll open that document as a PDF on your phones. If you can't get your QR scanner, go to my Twitter. It's right there, @HaldenHB. And the most recent post is a Dropbox link to exactly that PDF on the right. Once you've got that, feel free to click on any of the blue files, and where copyright permits, it'll take you direct to full text links of all the papers that I've just discussed. Thanks for having me.
Kat Evans from SmackForce News. Right, I'm going to be asking you some questions, and I'm only going to allow a yes or no answer.
OK.
Number 1, are we going to all live forever?
No.
Number 2, are you planning on stopping apoptosis?
No.
Number 3, did the pigs go back to work and contribute towards tax-paying status afterwards?
They made good bacon, so yes.
Okay, yes. All right. Which one of these, this is no longer a yes-no answer, which one of these procedures would you allow to be performed on yourself tomorrow if you were in cardiac arrest?
Well, I hope I don't need any of them tomorrow. That'll be a start.
Thursday after the party.
It's tough, that. I reckon EPR, I'm fascinated by that. That's the most off-piste you can possibly go. They are doing it on real people in Baltimore. I'd be up for giving it a go. I'd add it to the numbers. Yeah.
You'll add it to the numbers.
Why not?
Fantastic. Thank you very much for a very interesting talk.
Cheers. Thank you.